Well, thanks everybody for joining us today. We have another free webinar presented by Prepare.Ai. I'm Dave Costanero, the technical director here, and I'm joined by Foley Teasdale, our executive director. If you're unfamiliar with Prepare, we're a St. Louis-based 501c3. Our mission is to increase collaboration around AI and data science and related technologies, and ensure that St. Louis's tech economy continues to thrive. So we started this podcast. You check it out wherever you tune in. Some admin items. We're doing this as a webinar. We're also going to release it as a podcast. But if you're on the Zoom right now, click at the grid at the top right to see all the panelists. And if you want to pin the current speaker only, you can right click or click the little menu and pin that person. So what we're going to do is we're going to spend about 35 to 40 minutes chatting, and we'll leave 15 minutes at the end for audience Q&A. So please feel free to ask questions throughout in the chat, and we'll be monitoring those. We may weave them in. But we'll leave some time at the end to take audience questions. So Foley, do you want to introduce Philip?
Yes. I had to abbreviate Philip's bio because it is so impressive. So we're going to keep it a little short and sweet. But Philip Payne is the Janet and Bernard Becker Professor and founding director of the Institute for Informatics at Washington University in St. Louis. He's also the Associate Dean for the Office of Health Information and Data Science and the Chief Data Scientist for Washington University. He holds appointments as a professor of general medicine, medical sciences, and computer science and engineering in the schools of medicine and engineering and applied sciences, respectively. And in this capacity, he's responsible for the creation and oversight of comprehensive biomedical informatics and data science research, training, and support programs aligned with the health and life science enterprise spanning Washington University, BJC Healthcare, and a variety of regional partners. He's also involved with a number of really interesting national and international organizations. We'll put his entire bio in our webinar notes and our podcast notes. And then we're just going to dive right in. So Philip, thank you so much for joining us today.
Yeah, my pleasure. And thanks for the really embarrassing introduction with a lot of information. As I remind people, I think all that illustrates is that I've distilled down my core competencies to some combination of email, PowerPoint, and Zoom at this point in time.
Well, we are happy to have all of those skills with us here today. Some of you who have joined us may have been on a call almost a year ago with Philip. We kicked off a webinar series last spring at this exact time, and you brought so much incredible insight and information. So we were really excited to sort of revisit things a year later. So let me kick off with, how we talked last year about the informatics and data analytics needs at the beginning of the pandemic, and that was really about disease modeling and predictive modeling, capacity planning, population health management. What are the needs and priorities now? What are you all looking at a year later?
Yeah, it's a great question. So I'd start by saying I'm really glad we're here a year later talking about this next phase of the pandemic. When we talked last year around this time, I think there was a lot more uncertainty around, what the next 6, 12, 18 months held in store for us. And I think one of the, historical lessons that we'll probably look back at here in the St. Louis region was that it was really unprecedented collaboration between our health systems, our public health departments, our elected officials, and our community that allowed us to navigate this pandemic effectively and not experience those worst case outcomes that we may have imagined when we talked last time. And if you're a student of history like I am, in many ways it parallels the history of St. Louis, which was also a bellwether for navigating the Spanish flu. And so I think we've kept true to that, approach of, community engagement and collaboration to navigate a public health crisis. But then it does, lead to the question, what are we focusing on now? So some of the things I think will not be surprising to this audience. We're really focused on how do we identify those communities most at need for access to vaccination. So much like when we talked last time where we were worried about hotspots, where was the highest degree of disease burden? Did we have enough healthcare providers or facilities, and could people get access to them? Today, the question is, where have we seen the greatest burden of COVID over time? And where does that correlate with low uptake of vaccine? And then why is that? And the why is that question usually requires us to go out into the field and talk to people in the community. That's not a data science problem. That's a, public health and sort of cultural problem. But we're working really hard on that. We're working really hard to use the data that we have across our health systems and our public health departments to figure out where do we need to go and make sure that people that want this vaccine can get it. I think the second thing that we're really focused on is how do we give more data to our major employers, our universities, our elected officials to help us navigate this next phase of the pandemic? And in part, how do we navigate it if there are, say, pop-up clusters of infection or, areas where low vaccine uptake correlates with increased risk, or where are there particularly high-risk populations of individuals? And how do we take the right measures to mitigate? And so it's really sort of finding those pockets and being able to understand their needs and then employ sort of the right public health or other sort of measures to protect those populations that are at risk. And then I think the third thing that we're starting to really look at is how do we put all this data together and tell the story of what is generally referred to as long COVID, but what we would describe as the post-acute sequelae of COVID, because I think we really don't understand what the long-term effects for the individuals who have been impacted by this virus will be. And we have a lot of learning to do. We have to find out, what puts people at risk of these long-term effects. How can we anticipate who those individuals are? And I'll just give you a little sort of insight into the kinds of signals that we're seeing. Here at Washington University and BJC, we've established some long COVID clinics. So these are clinics where various providers can refer patients that they think are experiencing long COVID. And, it's a, few percentage points of the total number of patients that we've treated and discharged from our hospitals or seen in our clinics that have had COVID. However, if we look at our data and we see how many people were COVID positive, treated and discharged, and then within a 6 to 12 month period had visits for, say, pulmonary disease, cardiovascular disease, neurological disease that they did not previously have before their infection, that's probably 30 to 40% of our COVID patients. So the numbers that we're seeing today in our long COVID clinics are probably not the real numbers. And I would say that the number I just quoted, that 30 to 40%, is probably not that accurate either, because we still don't even know how to find those individuals that are experiencing long COVID. But I think what we will learn in the next several years is that it's going to be a high proportion of our patients, and we're going to have to find out how to take care of those people and address those symptoms and help them to live healthier lives with some of these, again, these post-acute sequelae of the disease. So those are the sort of big areas that we're really focused on right now. It's sort of moving to that next phase in the pandemic: vaccination, protecting at-risk populations, and figuring out what to do with long COVID.
So Philip, can you talk a little bit more about the long COVID, and are there any good theories out there about like what it actually is? Is it people with a certain genetic makeup, or people that have certain pre-existing conditions, or is there any pattern yet?
Yeah, so I wish we had better answers to that question. There certainly are some signals in the data, again, that tell us a bit about what we're seeing. Certainly people that had pre-existing autoimmune and other disease conditions that may put them at higher risk of sort of long-term complications from an acute illness are also more likely to experience long COVID. That's not surprising. But in equal measure, there are people that ostensibly, look as though they should not have any risk factors for long COVID, and they're experiencing it as well, which likely leads to sort of a working hypothesis that it's some combination of genetics, as you mentioned earlier, what we call the exposome, sort of all the factors that influence someone's health and wellness beyond the hospital and clinic. And it may, in fact, be tied up in, the sort of viral load and the specific strains of the virus that people were exposed to. And again, we know too little to arrive at a conclusion. And I wouldn't want to sort of hypothesize which one of those features is most important. But what I can say unequivocally is that we're doing everything we can to engage patients in clinical trials, to reach out to people that we think should participate in these studies, to collect biospecimens, to collect data at the point of care, to collect patient-reported outcomes, which are really important when we think about these functional and sort of, real-life implications of long COVID, and really start to put together the data sets that will allow us to answer that question you raised, because we're going to have to figure it out. But what I can say is I think it's going to be very complicated. The answer is not going to be simple. It's not going to be a single gene or a single strain of the virus. It's going to be something much more complex. And I will leave you with the thought that, this is not unique to COVID. We've known for some time when people have acute illness and they get treated in an ICU or other acute care setting, that there's often long-term sequelae of that illness once they're discharged from the hospital. And this type of syndrome doesn't look or feel a whole lot different from what we've seen with other people with critical illnesses. So this is sort of a fundamental challenge in human physiology and the impact of severe disease on human beings. It's actually why it's so important to take COVID seriously, even when it's increasingly smaller percentages of the population that may be at risk, because the implications of a COVID infection have not become any less worrisome.
Yeah. So the word you're using, sequela, is that their base root word sequel? I'm not familiar.
Yes,
Okay,
exactly.
So like an after effect.
Because why not use a good Latin word to make things just a little bit more obtuse? Yes, it's why I think actually long COVID is a great label for it. In clinical terms, we would call it post-acute sequelae, which is really sort of what happens after the primary illness or disease.
And does it look just like COVID with the same types of symptoms, or is it like a little muted, or is there?
So it's different, right? You see everything from long-term respiratory complications to what people have described as sort of a brain fog, where people have difficulty focusing, sort of neurological symptoms, sort of broader functional impact, where people just are not able to get back to their daily lives because they lack the stamina or ability to do so. And those are just a few examples. And I think, again, it varies broadly, from patient to patient. We have some people, for example, that just have ended up, and I should be careful using just, because this is an important and critical outcome, with long-term loss of taste and smell, and are now having to go through therapy to retrain them to be able to taste and smell, because it turns out that's really important in terms of navigating the world around us, right? So it's still broadly variable, but I think the way you described it, Dave, is sort of a muted version of some of the symptoms that we see in individuals who have had active COVID is not a bad description. And it does, again, have a pretty variable presentation. I think one of the problems, what I was alluding to earlier, is, we're really only seeing those individuals with the most severe long COVID symptoms who happen to get referred to these long COVID clinics today, because it's recognized for what it is. And I think what I'm really worried about are the people out in the community that are experiencing these long COVID symptoms that are just living with them because they aren't being recognized for what they are. And so I actually think the burden of this might be far greater than we understand right now.
Is there a data collection effort or some organization that somebody listening that might be going through this should, sign up or submit or file a comment?
So I certainly think for people who are experiencing symptoms and they think, I might have long COVID, I would encourage them to first start by talking to their primary care providers and asking about whether or not their health system has a long COVID clinic. My understanding is that all the major health systems here in the St. Louis region have long COVID clinics, and that's the place where we're going to reach out to people to participate in clinical studies to better understand this. If you step back from that a bit, we're also part of a larger initiative through the National Institutes of Health, which is called N3C, which is the National COVID Cohort Collaborative, which is an effort to pool data across the major academic health systems in the country, and to use that pooled and de-identified data to study sort of the natural course of COVID and all the different outcomes. And that group is now starting to transition to focus more on the post-acute sequelae or long COVID. And there are actually a number of new programs that are being stood up today, which would be new clinical studies to recruit patients to participate in tracking long COVID. So I think that's going to be an opportunity in the very near term. And I'm talking a matter of just a few months, where you're going to see places like WashU, BJC, and others advertising that we're seeking individuals who are experiencing these symptoms to volunteer to participate in these studies so we can better understand the disease. So it's a big focus for the National Institute of Health to bring these data together to support large-scale studies. Because I think the other problem is none of us have quite enough of a sort of population at an individual health system to be able to study this in its entirety. So we really need that national scale data set if we're going to dig into the details.
Mm-hmm. Cool. Let's talk about infection projections that you made towards the beginning of the pandemic versus actual? So like a
Right.
back test, where do we see divergences from what we expected at the beginning? Are there any interesting or unanticipated nuggets worth exploring of like, hey, things turned out different than we projected?
So the one thing I would say is we were, and I don't mean this to be self-congratulatory, but we were remarkably accurate with our projections. When we look back to even, over a year ago, we look at the projections that were being generated by the team at BJC and WashU and with our colleagues at Mercy and St. Louis University and SSM, all in support of the pandemic task force. What we learned was the models that we built were very tailored to the population here in St. Louis. And by and large, we tracked very closely with those models. In fact, it was a little bit alarming because when there were surges in patients and we would show a model that showed sort of a rapid increase in patients, we also knew that when we looked at that model, we were probably looking at what was actually going to happen in our healthcare delivery systems. As we gained more confidence in the model, it also allowed us to sort of understand when we were at critical inflection points in the pandemic and needed to prepare for some of the more sort of substantial burdens on the health systems. The interesting sort of, tangents that the models took in no particular order of importance. One of the interesting areas is, where we were seeing sort of a divergence in overall patient burden from ICU load. So there were times where the total number of cases in the region were declining, but the demand for ICU beds did not decline at a commensurate level. And you would think, right, if the disease burden in the community was declining, so would the number of patients that were most acutely ill. And we have some working hypotheses about that. But what we found is, oftentimes you'd have a trailing indicator, right? So, several weeks between looking at testing data versus hospitalization. And at different times in the pandemic, different at-risk populations, older patients, patients with chronic diseases, et cetera, would be disproportionately impacted. So for example, we saw younger patients, getting more ill later in the pandemic, in large part because there was increased natural immunity in the older patient population that we would have assumed would have been most at risk. So there were some divergences where the sort of decline in overall case rate didn't track as closely with ICU capacity as we might have imagined. And I think that was in part because we didn't really understand the biology of the disease or the biology of natural immunity of the disease, especially before we had a vaccine. I think the other area is we didn't anticipate the degree of geographic variation. So we could look at a curve that would show us sort of the overall sort of positivity rate or inpatient caseload or ICU caseload for the region. And we always tracked very close to our models. But if you got down under the hood and you looked at it by sort of zip code or census tract, you began to understand that there was a fair degree of variability in sort of how different parts of our region contributed to that overall curve. And I don't think we had fully understood what that was going to look like at the front end. It's somewhat explainable by things such as sort of, variable public health policies, differences in demographics, differences in clinical practices. In some areas, providers were able to treat more patients at home through telemedicine, whereas in other geographies, those same patients would be admitted to the hospital. So we didn't really model that very well, and that was important in terms of understanding the caseload. I think it actually tells you a lot about a sort of pandemic like this, that the true effect is local, right? It's not at the state level, it's not at even the city level, it's really block by block, zip code by zip code. And so while the overall model stayed true to sort of their trajectories, these sort of, more granular projections were much more variable than we expected. And then I think the third thing, which our models were not built to predict, but turned out to be really, really important, was sort of the disproportionate impact of the disease on some of our most at-risk populations. So not surprisingly, if I showed you a map of where the sort of greatest disease burden existed for COVID, and I overlaid that with an indication like a social deprivation index that tells me about sort of socioeconomic status, access to healthcare, et cetera, those tracked very closely with one another. And I think where we were a bit more surprised, I mean, it's sort of intuitive that that would happen, unfortunately, and it's sort of a glimpse into some of the fundamental inequities of our healthcare delivery system and our public health infrastructure. But I think one of the other things we learned about that was that this happened at a very, very sort of granular level in individual healthcare facilities, where all of a sudden we were seeing, for example, numbers that told us that African American patients were seeing anywhere from a 2 to 4-fold higher risk of hospitalization, admission to the ICU, mechanical ventilation, or death from COVID. And we knew that that would likely be the case, but we didn't anticipate sort of the degree to which that would be magnified. So the total case numbers certainly held true, but the proportionality of impact on disadvantaged communities, while we anticipated it, was far greater than we expected. And I think that tells us a lot about the problems in our healthcare system, or lack therein, that we have to tackle longer term.
I'm wondering if that it leads me to questions around the vaccine and getting everyone vaccinated. And, I know anecdotally, I feel like most of the people I know my age did not get a vaccine locally. They, I went to a Walmart in Pittsfield, Illinois, where they had a waste protocol list, and they were so grateful. They literally said, please have more people come up. So can you talk about distribution and how, if we saw everything that we learned through, watching the impact across different populations and different zip codes and different street blocks, are you able to apply that data to try to get the vaccination to the right places as quickly as possible?
So I'll start by making a comment. We've been very quick in a lot of contexts to criticize the logistical operation around the deployment of these vaccines. But I do think it's important to take a sort of step back and realize that as a logistical and public health challenge, we had never done anything like this before. No one had really contemplated how would we vaccinate the entire adult population of the United States in a period of just a few months. So it's intrinsically hard. And because of the way our vaccine distribution, supply chain, and public health systems are built, that ultimately became a local problem at the state and sort of regional and even, city level. So I think for starters, our public health, professionals, the people involved in distribution at the state level and at the federal level, I think we're trying to do something that there was no playbook to work from. Now, you might argue that there was a playbook in sort of the broad infectious diseases domain, except that playbook was largely built around a sort of rapid deployment of a treatment that required a single dose. And I would encourage everyone to sort of recognize that there's a profound difference from a logistical standpoint of deploying a treatment for a pandemic that requires 2 doses with specific timing in between those 2 doses. And that was something that we didn't have a plan for. So with those sort of exculpatory statements, now back to the questions you asked. I think early on, we had difficulty sort of understanding the proportionality of where vaccines should be deployed. And so we ended up, at least in the state of Missouri, with a situation where we had a lot more vaccine in rural municipalities than we did in the city or county of St. Louis, or quite honestly, in Kansas City or in Columbia or other sort of major population centers. And what this led to was sort of the situation you described earlier, which is where people were traveling out of the city, out of the county to go get vaccines earlier, where they could. I think over time we did adjust and we got much better about deploying vaccine in a proportional manner to meet the needs of the population. But it was a bit chaotic at first because we were literally learning on the job. I will tell you, I was immensely proud here. We had a number of high, throughput vaccine delivery mechanisms linked to our major healthcare provider organizations. And those organizations like BJC and WashU, Mercy, SSM, and SLU, and others really delivered the vast majority of vaccine doses in this region. And we literally were creating, a vaccine delivery platform out of thin air and, overnight. And I think we learned a lot and we got a lot more efficient much more quickly. But it leads to the question that you asked around sort of targeting vaccine delivery. So, there's a really important effort, and I'll speak to sort of the example from BJC and WashU, and I know our other health system partners are doing the same. But Jason Purnell and his team at BJC are leading a very targeted effort, working with community groups, working with members of the community directly, using all of the data we have to figure out where and when and how we can deliver vaccine where people are, meet them where they are, answer their questions about the vaccine, make it easy for them to get their doses, and really sort of demonstrate community buy-in to getting vaccinated. And this is, as I often describe to it, a function of retail politics, right? This is the kind of vaccine campaign that doesn't happen in a big centralized clinic like what we were using early in the vaccine campaigns, but rather something that happens block by block, church by church, community center by community center. And that's the hard work that's in front of us today. People have every right to ask questions about the vaccine and to have the opportunity to learn about it before they make a decision to get vaccinated. So we have to find a way to do that and respect that need, and then simultaneously promote vaccination as quickly and as safely as we can. And I will say unequivocally, and we were chatting about this before the start of this, recording, I have absolute faith in the safety of these vaccines. The science is incredible that is behind these vaccines. And I know many people feel that it happened very quickly, but it happened quickly because of decades of basic science that preceded this pandemic and fortunately aligned with the need that we had today. And we need to make sure that that message resonates and that we, again, meet people where they are and get them vaccines. And, our health systems are committed to doing that. I know our colleagues at Mercy and, at SSM and SLU and St. Luke's and many others are doing that, as are our federally qualified health centers and all the other sort of safety net providers. But it is a true community effort. And I know that term is used over and over and over again, but everything we've done from the very first days of the pandemic until now has been all about that community effort. And I don't think it'll be any different when we talk about vaccination.
That leads me to a big percentage of the population that hasn't been vaccinated yet, and that is kids.
Yes.
What do we do about the kids under 12? It's now 12 to 15 has been.
Yes. So I have one of those kids, as you know. So I have a 9-year-old, and it is a big challenge for my family, right? Both my wife and I are fully vaccinated and have been for some time. But we're not able to sort of return to whatever our new normal can or should be until our daughter is vaccinated. And many people will say, well, the risk for children is very low, and I leave it to my pediatric infectious disease colleagues to speak to this more fully. But you're right, the risk is low, but the risk is not zero, and that's a personal decision that every family has to make. I'm quite optimistic that we will see the opportunity to vaccinate all of our children this fall. I know that our experience just deploying the vaccine for the 12 to 15-year-olds shows that we can quickly stand up the ability to get those doses to children. And I'm confident that we'll do that when we get the authorization from the FDA to dose younger kids. I'll speak from a personal level, and I know many people are nervous about providing the vaccine to their children. I will say personally, I said earlier that I have a lot of faith in the safety of this, vaccine technology, especially the mRNA technology. The day that they opened up the list to register interest in the clinical trial for pediatric dosing of the vaccine, I talked to my daughter. I asked her if she wanted to be on that list. She said yes, and she's on the list. I don't know if she'll get into that trial, but I want to be clear. It's not just me speaking hypothetically. If I got the call today to say, there was a dose as a function of this clinical trial available to my daughter, I would absolutely have her vaccinated because that's the pathway forward for all of us to really have that confidence to go back out into sort of this new normal. So we still got a lot of work to do. I think that's the biggest thing to the question that you're asking. How do we move the needle and get more of the population, because it's a big proportion of the population who are not vaccinated right now in the absence of sort of widespread access to pediatric vaccines. So we're making great progress, but we also shouldn't declare success too early until we make sure everybody who wants and needs a vaccine can get one.
Yeah. Wow.
So now we were talking a little bit about this before the call. We're kind of mask requirements are in flux, they're changing. If you had your magic wand as far as like communicating, the scientific method, like this, how should the communication process go when talking about this? Hey, we've got it all figured out, or hey, we're doing some science. Here's the boundary of what we know and we're sure of, and we're working on XYZ things. What are your thoughts?
Right.
on
So
that?
I think I'd start by saying I don't think there's anybody working in the broad sort of health domain that would argue that we had a comprehensive win when it came to our messaging around this pandemic. And I'm not an elected official, so I don't have to make those hard decisions, and I'm not a public health officer, so I don't have to make those hard decisions. But at a personal level, I would say two things. One is that we really needed to deliver simple and consistent messages. And the reality is, because we sort of really decentralized decision-making around policies and messaging, this was an area where we fell short of that goal, because the messaging varied broadly based on who was drafting it, who was delivering it, and who was making those policy decisions. And that lack of consistency created a lot of confusion, and confusion leads to people, having a appropriate degree of discomfort with sort of following these policies and guidelines, without asking questions. But I would say, you asked me an important question, and we were talking about this before the recording started. One of the things that's troubling to me is that there have been a lot of instances throughout the pandemic where our understanding of the disease and how to prevent its spread and how to treat it, and now how to ultimately prevent it through vaccination, has changed. And that's changed because it was, as it is named, a novel coronavirus that we had to study and understand. And we had to use the scientific method to study and understand it, which means that we had to form a set of hypotheses. We had to go and collect data. We had to interpret that data. And if those hypotheses weren't proven to be true, we needed to draft new hypotheses and repeat that process multiple times. And that meant that at any point in the pandemic, our understanding of the disease, how it was transmitted, how it should be treated, and how it should be prevented changed. And there seems to be a broad belief system that when scientists say, this is our best understanding of the disease, and then say a month or 2 months later come forward and say, we have new evidence, that somehow that is an indication that those scientists lack credibility. And I think that that really hampered our ability to have a science-based conversation around how to navigate the pandemic, because there was a broad thought process that changing evidence equated to a lack of credibility, when in fact the changing evidence indicated that the scientists were in fact employing a rigorous scientific method and making decisions based on the best available evidence we had today, not dogma, right? And this is where sort of science and politics are often not particularly compatible with one another, right? Because you want simple, clear, consistent messaging in politics, and in science, it's incomplete and messy, and it changes as we understand a given phenomena better over time. And so I guess it does beg the question, as a society, how do we create greater understanding of, honestly, how the scientific method works? Because I don't believe this will be the last time that we will be faced with a health crisis where we're going to have to quickly learn and come up with a new approach to keep people safe. And, if we can't come to grips with the fact that it's going to involve sort of this iterative scientific process, we're going to run into the same credibility gap that has prevented us from having a science and data-driven conversation around how to navigate this pandemic. Because I think we might all agree, I would hope in this call, that we didn't always have a science and data-driven conversation around how to manage the pandemic. And, as a scientist, I find that deeply troubling, because I do not believe that sort of, picking a single truth at a single point in time and dogmatically applying that throughout a complex situation like this pandemic would yield the results that any of us should expect from what is arguably the greatest scientific enterprise in the world, in this country, right? We've invested so much in basic science and so much in clinical and translational research. And the NIH is, the envy of the world in terms of health research. And we used all of that intellectual horsepower to get us to the point that we're at today. So I think we need to acknowledge that and also respect that scientific process that makes that enterprise work, which is why we've been able to have this conversation today and not the worst case scenario that we may have contemplated, a year ago. So I guess it's a little bit of a soapbox moment, but I feel like this is a place where we really fell short, and we need to have a real conversation as a society around this issue, because again, I don't think this is going to be the last time that we have to have a conversation like this.
Yeah, I think that's so important, Philip. You know, the state of public discourse, political and kind of in that realm, is just not does not include enough nuance in all of the hard problems that we're talking about. Are very complex. It's not usually the case that it's easy A or B decision. You know, if it's an easy decision, if it's an easy issue, it's been tucked away, and now all we have left is the hard, complex, sticky things,
Right.
which require science, which require probabilistic thinking, you know, subtleties, segmentation. So we definitely need more scientific, statistical thought and reasoning in public discourse. Could not agree more. So let's see, Fully, what do we want to turn to next? We've got 20 or so minutes left. Do we want to talk? I'd like to get an update on, Philip, you had mentioned at some point working with synthetic data, that there's a big project going there and I don't know if it's directly related to COVID, but is there an update on that?
So yeah, that's a fantastic question. So you know, we do in fact have a very large synthetic data project underway as part of that N3C initiative that I alluded to earlier, and we're actually leading it here at Washington University. So we're very fortunate to be able to help sort of, you know, push the horizons of the use of synthetic data. And the reason why
to avoid using private data.
I was just going to get to that.
Yeah.
So,
great.
you know, the value of synthetic data is it allows us to sort of separate the really critical sort of data elements from people's individual identities. And as opposed to other methods that we've used in the past that sort of scrub potential identifiers from the data, and those methods are very lossy. We lose important data elements. With synthetic data, which is more of an artificial intelligence-based approach, we're able to produce these synthesized data sets that look and feel like the real data, exhibit all the same statistical features, but have no linkage to the identities of the people from whom that data was originally informed or derived. And so what that means is that we can analyze and sort of use that data in contexts where, you know, otherwise privacy and confidentiality risks would have prevented collaborative efforts. So in the context of, you know, the N3C initiative I talked about before, we've been doing just that. And actually we've been producing right now what we believe to be the largest synthetic data set derived from a patient cohort that's ever been used for research. So within the N3C initiative, there are literally millions of patients who had their data in that data set. And we're able to produce a synthetic derivative of that data for every one of those people. And that opens up the door to rapid scale collaboration around the use of that data while protecting essential privacy and confidentiality risk. And so we're doing that right now today. It's something I'm really proud of because I think, you know, the essential question that we have to deal with is we have an ethical and moral compact with our patients, which is to protect their autonomy and ability to make decisions about where and how their data is used, while also making sure that every time we have a patient encounter, we're learning and improving the care that individual receives, their family receives, and their community receives. And I think when you talk to a lot of our patients, they expect us to do both. And that's very hard to do. And synthetic data is a really powerful computational approach to overcome some of the barriers that have made that balancing act so hard to strike. So I'm really excited about this. I think it opens up the door to a lot of the advanced AI and other sort of, you know, computing research that we've alluded to during this discussion. And actually, it speaks to, I saw one of the questions in the Q&A was around sort of the equal number of failures of sort of computational approaches to understanding the pandemic as compared to the successes. And clearly, I'm talking about the successes today. But you're right, there are a lot of failures. And one of the best ways to sort of fail fast and understand where an algorithm is biased or is not going to produce the results that we anticipate or results that have utility is to be able to have a sufficiently large and diverse and representative data set upon which you can train and test that algorithm. And almost all of the failures that we see is when these algorithms are trained on small, incomplete, biased data sets without that degree of rigor. So the synthetic data work that we're doing as part of N3C, this largest synthetic cohort that we've ever seen in the context of COVID, is an ideal vehicle for overcoming those barriers. So I believe more data that's better understood and more accessible and transparent is ultimately the solution to sort of the bad AI problem that we often talk about.
And that's awesome. So it sounds like that's your answer to the question about the failures, that the models were just using too limited data.
My only other comment about that question is it's a really good question, because I think one of the problems in sort of, especially the world of artificial intelligence, is we spend a lot of time talking about the things that work, and we don't spend a lot of time talking about the things that don't work. And we need to create a better mechanism for sharing those failures so that we can learn from them, because almost every time one of these algorithms fail, it's because of some constellation of those factors that I just talked about earlier. And if we don't surface that and share that, then other people are going to repeat the same mistakes and have the same negative outcomes. And so we really need to, as a community, the AI community, really come to grips with the need to share negative results and value them just as much as we value positive results.
That makes perfect sense. Dave, you want to go next?
Sure. So we're starting to read and digest some of these questions from the attendees. So let's see. Someone says, I participated in some folding at home experiments during the initial months of the pandemic. And so that's a program where you can use your personal computer, and they will send you some data to crunch. And so it's like a distributed protein folding simulations. So this attendee saying that did some of that, wondering if that was fruitful. Did any of these efforts shed light on any of the data coming out during the pandemic? I know that mRNA seems to be coming out as the clear winner of treatment for protection. Just wasn't sure how any of these problem sets helped in current or future diseases.
Yeah, so for starters, I love any question about folding at home, because one of the key partners in driving that platform is actually our Center for Science and Engineering of Living Systems, which is a program in the McKelvey School of Engineering at Washington University. So always love an opportunity to talk about that. I think a lot of important findings were generated from that, because one of the big questions early in the pandemic was not only, what proteins were being expressed by the virus, but also sort of what did that mean in terms of therapeutic targeting, and actually being able to model the folding of proteins to understand their conformation, their shape, and how other molecules may interact with them is a central part of therapeutic design. And so I believe that distributed computing enterprise that Folding at Home provided really drove a lot of the early stage proteomics research around sort of, both diagnostic and therapeutic approaches to COVID. And proteomics is a great example. Nobody has the computational capabilities sort of in their single, institution to tackle a problem of this scale. And it's one example of many where sort of distributed or crowdsourced computing played a major role in sort of our early response to the pandemic.
That's super cool. So we had a question around variants. Considering the situation in India and the havoc that the virus created there, any thoughts on, should we be worried about variants? Are we going to see those new variants here? And does a patient's travel history that was collected during testing speak about where variants may be coming from?
Yeah, there's a lot to unpack in that question. So for starters, I think we should always proceed with an appropriate degree of caution to try to understand what the new variants of this virus look like and what they mean in terms of transmission rates of the disease, or whether or not the current vaccines that we have provide adequate protection. And that's going to require constant vigilance. The one thing I would say, though, is that many people are worried when they hear about new variants. The reality is that the sort of process of beginning to vaccinate the population of the globe, right, and all the other mitigation steps that we've taken places evolutionary pressure on the virus. So the emergence of these variants is both expected and normal. This is not something unique to this particular virus. It's something that we would have imagined would happen. Now, the question is, are we doing everything we can to protect against those variants? Because the most important thing we could do is make sure that we get as many people throughout the world, not just in the United States, vaccinated as quickly as possible to limit the number of avenues via which these new variants can get transmitted. Now, I think it's exciting. In the last couple of weeks, we've seen some important moves by the United States to start sharing the extra vaccine doses that we have. I know a lot of people say, why don't we share more vaccine doses? I assure you, it's a very complex thing to do because of the cold chain and the delivery mechanisms and all the other logistics that go along with it. The same logistics we talked about earlier is being challenging here in the US. But it doesn't mean we shouldn't do it. And I think a lot of important efforts are happening there. I think travel history is one way of understanding when we see someone with an infection and we're trying to understand, but frankly, sequencing more of those patients, both host and viral genomes, is really important. And I would argue that here in the United States, we are still not necessarily sequencing at the scale that I personally, as a scientist, would like us to do. So the most potent tool we have is just to understand the genome of these, viruses and how they've changed over time. And we know how to do that. It's to, get those samples, sequence them, and compare them across different groups of individuals getting infected and understand the differential outcomes. So there's a data dimension to that, but there's also a public health and global health policy dimension to it. So I would just say, am I surprised that there are new variants? No. Is this something unique to COVID-19? Absolutely not. Should we be vigilant? We should. And I think the biggest question is, are we getting enough vaccine to those parts of the globe that are most at risk? And are we thinking very critically around how to use here in the US our sequencing capacity to understand what's happening? We're very fortunate. We worry a lot about the percentage of adults right now in the US or eligible individuals getting vaccines and where we're at in terms of achieving what has been referred to as herd immunity. And I think that's a complex question unto itself. But in equal measure, if you look at the percentages globally, we have a long way to go. And we need to see similar percentages globally if we're really going to get this pandemic under control.
Do you think it's a situation where we're going to end up doing boosters like we do for the flu?
Yeah, I think that's outside of my direct realm of expertise, but I will say there are clinical trials underway right now to look at the impact of boosters. There's emerging evidence, for example, about giving a third dose to people who are immunocompromised or live with someone who's immunocompromised. So I would say there's a lot of science going on right now to ascertain whether or not that'll be necessary. Do I think that this virus is going to become endemic and, not be eradicated and become something akin to, influenza, where there's sort of a season that often correlates with the winter and, we may need to do additional vaccination, in order to address new variants? I think that's a not irrational sort of conclusion because I don't believe we're going to eradicate this virus at any point in time, at least not in the foreseeable near future. Again, that's just my opinion. I'd love to be proven wrong about that, but I think, the degree and sort of depth of spread of the virus at this point probably precludes, anything other than sort of an outcome like that.
Someone else is asking, you had mentioned the rollout of the vaccine was necessarily decentralized. What are some ways that WashU, BJC, and other health partners like SSM and Mercy have employed long-term solutions? And is a sense of scalability in terms of applicability to other potential outbreaks been considered using the data that your team has gathered or cleaned?
Yeah, so I think the takeaway is that we collaborated, much like we did during the acute phases of the pandemic. We collaborated in equal measure to understand sort of how we would geographically distribute different vaccine delivery sites and mechanisms. We worked across the health systems to load balance in terms of the amount of vaccine coming into the region and how that would be distributed across those various locations based on demand. And we also did things like standardize the types of questions and prioritization schemes. I think this is really important that we would use early when vaccine was not widely available to sequence those individuals who had pre-registered and said they wanted a vaccine. And I can't emphasize enough, it goes back to the communication issue that we talked about earlier, that consistency in the way in which we made decisions around who was going to get a vaccine, when, and where was really important, so that we didn't create a sort of inequitable access situation based on the different patient populations that we all served. And there was a strong degree of coordination there. I think the takeaway is we learned how to stand up that sort of capacity very rapidly. And we now have that infrastructure and that knowledge. So the challenge to us at present, and we're having this conversation, is how do we maintain that infrastructure over time, after we get out of this next phase of the pandemic, and how do we maintain that knowledge? Because there's really two paths we can go down, right? One is that we basically say, okay, the emergency is over, we'll shut down that infrastructure and we'll go back to business as usual. And, we would be probably okay in the near term. Alternatively, we say, there's real value to having this ability to coordinate at a data-driven level when we're tackling population health challenges and figure out how to sustain it. And actually, one of the things I'm most excited about is through the leadership of a group known as the Regional Data Alliance that's based out of the University of Missouri, St. Louis. We're starting to have that conversation around how do we convene all the stakeholders and have a critical discussion around how do we maintain what we built so that it's ready the next time we need it, whether that be for a pandemic or it be for managing the impact of gun violence, or it be going after chronic diseases that disproportionately impact communities that don't have equitable access to healthcare, and all of the stops in between. And I think you can tell from the way I'm describing it, I sure hope we find a way to sustain that infrastructure, because I think we learned a lot in the last year and a half. And the question is, how do we make sure we don't lose that pathway? There is a cautionary tale, right? After 9/11 and then some of the bioterror attacks that followed, there was a substantial national investment in bioterrorism surveillance and management systems. And for a period of about 5 to 7 years, substantial investment. And then people lost interest and that investment went away and that infrastructure went away. And by the way, that infrastructure would have been incredibly useful during the current pandemic that we just experienced, but it had been allowed to become nascent because sort of the sense of urgency was lost. And so I think that's the challenge. How do we maintain this type of infrastructure over time, maybe without the urgency that we feel, today, or that we felt over the past year?
Yeah. Humans aren't long term is not easy for us. For the disadvantaged communities in St. Louis, this is a question from an attendee. What was the proportion of vaccines that went to those communities, and how has that changed the spread or mortality of COVID over time?
Yeah, so the reality is we alluded to this a little bit before. The impact of the pandemic has been entirely disproportionate, and especially on some of our most at-risk communities and those that have the least access to healthcare or sort of health resources. I think the positive that I would put on that lesson learned is I think it's really put an intense focus on this issue that has already existed for some time, but has been maybe brought to a little bit more of a sort of visible status in our region. I think that we still struggle today. The very same communities that we knew were disproportionately impacted by the virus are now not necessarily seeing the same degrees of uptake of vaccine as we see in more advantaged populations. So the same access and equity and sort of trust issues, quite honestly, which are appropriate in this context. There's a lot of reasons why the trust fabric is not robust in these most disadvantaged communities. We still haven't solved for that. And so the question is, much like the data infrastructure, are we going to learn from that and really talk about that and tackle these problems? Because, I think I've shared this with you before. One of the reasons why I came here to St. Louis, 5 years ago to lead this institute and build this program at WashU and working with our partners in the region was that I looked at St. Louis as a microcosm of all the challenges that the U.S. healthcare system faces. A lack of access, inequity, a lack of focus on long-term wellness, right? Affordability issues, a lack of ability to really implement precision medicine at scale, where we actually use our knowledge of the genome to improve quality, cost, and outcomes. And I could keep on going down that list. So we should be using this crucible of the pandemic to really understand those, critical issues and not lose sight of them, because I think that's what comes next. And I'm encouraged. I think some of our recent elected officials have a very sharp focus on this, both at the local and national levels. And the question is, how do we sort of build a policy agenda? How do we look at sort of the role of the community as a sort of co-equal partner with healthcare delivery systems, and how do we energize sort of a true community-based approach to solving these problems? Because it's not just the hospitals, right? It's not just the insurers. It's truly going to take this community-based effort if we're going to overcome some of these challenges, because it's got to come top down, bottom up, and sort of middle out all at the same time, which is very hard to engineer, I think, as we all know.
Definitely. Well, I think, Philip, we're out of time here. We want to give you the last word, but first, I want to just thank you so much. We covered a lot of ground here. This was super interesting and informative. And thank you so much for joining us. Is there anything that you want to say in some parting words that we didn't cover, or anything that you'd want to close with?
The only thing I would just say is, first of all, I love forums like this because I feel like this is a really activated, community here in St. Louis that has a lot of the expertise and a lot of the drive to tackle the problems that we've talked about today. And when I talk about a community-based approach, this is it, right? Having the dialogue and figuring out who the partners and allies are that are going to move this agenda forward. So I love the opportunity to talk with everybody that's participated today. I would just leave you with this. I think we should all be immensely proud of what we've done in the last year here in St. Louis. It's been incredible. And for me, it's probably, at least I hope, a once in a lifetime opportunity to truly practice what I normally would teach or do in the laboratory. And I'm so thankful that we could marshal all that intellectual horsepower, all that commitment to collaborate to really tackle one of the greatest problems of our time. But that success should not breed complacency. And I think that's the real question for us next. And that's the question I alluded to earlier. So I cannot say enough how we need to make sure that 5 years from now, we've done something that's meaningful and sustained as a result of what we've learned here. And it's going to require communities like the one that's, participating live or listening to this podcast. So I appreciate the forum, and I hope we all continue to have this conversation moving forward.
Awesome. Thank you so much. If anyone wants to share this, we will share the video. We will also share the podcast, and you can spread it out among friends. And then I do want to say, in the beginning of July, we're going to have one of the leaders of the Pfizer vaccination team speaking to us. So you'll have to tune in for that as well. Philip, thank you as always. You're so generous with your time, and we are grateful to have your cooperation and engagement. And we're very happy you're here in St. Louis. It's a better place because of you.
Thank you.
All right. Thanks, everyone. Take care.
Bye all.